Welcome to the Deep Dive. We take complex research and, well, make it useful for you. Today, we're tackling something huge in eye care: myopia, nearsightedness. It's exploding globally.
It really is. It's way beyond just needing glasses. We're talking about a major public health issue. The projections, half the world's population myopic by 2050. That's staggering.
And it's not just blurry vision, is it? It leads to serious stuff later on.
Exactly. That eye elongation, the stretching, it increases the risk for really severe vision-threatening conditions. Think retinal detachment, glaucoma, things you absolutely want to avoid.
So as we get better at managing it, especially in kids, slowing that growth down, how we track that progress becomes absolutely vital.
Couldn't agree more.
Which brings us to today's deep dive, aimed right at you, the practitioner. We're looking at a study comparing two big players in biometric devices for myopia, the MYAH from Topcon and the Myopia Master from Oculus.
Yep. And the angle here is interesting. It's not just which machine is better. The researchers asked something maybe more fundamental. Does years of clinical experience actually matter when using these new sophisticated devices? Or can someone less experienced get results just as good?
Okay, let's break that down. First things first, the key measurement. When we're talking myopia control, atropine, orthoc, special lenses, what's the number one thing we're watching?
That would be axial length, AL. It's basically the physical length of the eyeball, front to back, cornea to retina.
Right.
If that length is increasing too quickly, myopia is getting worse. So the whole point of treatment is slowing down that AL increase, our main target.
And these machines, the MYAH and Myopia Master, they use fancy optics, right? Interferometry, to measure that length super precisely.
Exactly. The MYAH uses low coherence interferometry. The Myopia Master uses dual partial coherence. Different tech, but both aiming for high precision on that AL.
Gotcha. And besides AL, what else did this particular study measure?
They looked at three other key parameters. The corneal curvatures, K1, that's the flatter curve, and K2, the steeper one. Gives you the cornea's shape and power.
Okay.
And also the white-to-white distance, WTW, that's the visible iris diameter, side to side. Important for, fitting some types of contact lenses.
All right, that sets the stage technically. Now the study itself, because the people doing the measuring, that's where the interesting part is.
Yeah, it was a pretty clean setup. Perspective, cross-sectional. They took 42 healthy adults, young adults, average age around 24, 25, and they just looked at their right eyes. Nice cooperative group.
But the operators running the machines, polar opposites, experience-wise.
Deliberately so. They had an expert, an optometrist with over 10 years in practice, real clinical veteran,
Okay.
and the non-expert, a final-year optometry student, still learning the ropes.
Wow, okay. So a decade of real-world practice versus someone about to graduate. But here's the kicker, right? Neither of them knew these specific machines beforehand.
That's the crucial bit. Neither had ever used an MYAH or a Myopia Master before this study. They both got the exact same basic training. How to seat the patient, use the joystick for alignment, follow the guides on screen, standard stuff. Then off they went, taking measurements.
And that manual part, the joystick alignment, that's important. It's not fully automated.
No, not completely. You still need to manually center the device, align it to the patient's visual axis. There's skill involved, or at least that's the theory they were testing.
Right, because you'd assume the person with 10 years of practice, better hand-eye coordination maybe, better patient handling, they should get better, more consistent readings.
That's exactly the assumption. Does all that general clinical skill translate to better performance on this specific task with this specific tech? That was the question.
So let's start with consistency. Inter-observer repeatability. If the same person measures the same eye multiple times, do they get pretty much the same answer? How did that look?
That looked really, really good. Excellent, actually, for both the expert and the student. On both devices for all the parameters.
Really? Even the student?
Even the student. They use the interclass correlation coefficient, ICC, to measure it. Think of it as a score from 0 to 1, where 1 is perfect agreement. The scores were consistently high, like 0.98 or better.
So an ICC that high. Clinically, that means the measurement is reliable, right? What you get once is pretty much what you'll get again.
Essentially, yes. It tells you the measurement itself is very stable when done by the same person following the protocol. You can trust the number.
Was one measurement more consistent than others?
Oh, definitely. Axial length, AL, was the star, as you'd hope. It hit an ICC of 1.0 perfect repeatability. And the coefficient of variation, which measures spread, was tiny, less than 0.06%. For both operators, both machines. Rock solid.
Okay, so the devices nail AL consistently. Any parameter slightly less consistent, comparatively speaking.
Comparatively, yeah. Yeah, the white-to-white, the WTW had a bit more variability. Still good, mind you. ICC is up around 0.99, but measuring that wider surface diameter is just inherently a bit trickier than the very precise optical path length for AL or the focused corneal curvature.
Got it. Okay, consistency within one person is great. Now for the big question, the one the study was really set up for. Inter-observer agreement. Did the expert's decade of experience give them an edge over the student? Did their results differ significantly?
And here's the punchline. Prepare yourself. No.
No, like no difference at all.
Statistically speaking, no significant difference between the veteran optometrist and the final year student for any of the measurements AL, K1, K2, WTW on either the MYAH or the myopia master.
Wait, so you're saying I could train someone relatively new on these machines, give them the basic rundown, and their axial length measurements would be just as reliable as someone who's been doing this for years?
Based on this study, in this cooperative adult group, yes, that's what the data showed. The p-values were all high, meaning there was no statistically significant difference between the two operators' results. Experience, in this specific context, didn't provide a measurable advantage in the final number.
That's kind of huge. It really changes how you might think about staffing and training, doesn't it?
It absolutely does. It suggests that for these modern devices, the reliability is baked into the technology and the standardized procedure. As long as the operator gets that basic device-specific training and follows the steps, the machine delivers consistent results. It's less about decades of general feel and more about following the process.
It's a validation of the engineering, really.
Exactly. The human experience factor seems less critical than the machine's precision and the protocol.
Okay, mine's slightly blown on the operator front. Let's shift gears. Inter-device agreement. This is crucial for patient care over time. If my patient gets measured on a MYAH at Clinic A, then moves and goes to Clinic B, which uses a myopia master, can we trust those AL numbers? Can we mix and match?
For axial length, the most critical one for tracking myopia progression, the answer is yes. Good news there.
Phew! Okay.
The study found no statistically significant difference between the AL measurements from the MYAH and the myopia master. The agreement was excellent. ICC basically 1.0 again.
So for AL tracking, switching between these two devices seems safe.
It seems safe. The study supports using AL measurements from these two devices interchangeably for monitoring patients over time. That's a big deal for continuity of care, right?
Definitely. But I sense a but coming. You specified AL. What about the other measurements? K1, K2, WTW?
Ah, yes. Here's where we need to wave a big caution flag. For the corneal curvatures, K1 and K2, and for the white-to-white distance, WTW, the devices did not agree.
They showed significant differences.
Yes, statistically significant differences, highly significant actually, with p-values way down below 0.01. They systematically gave different results for corneal shape and diameter.
Okay, so not interchangeable for those. Was there a consistent pattern to the disagreement? Did one always read higher or lower?
There was. The myopia master consistently measured the cornea as being flatter, so lower K1 and K2 values, meaning lower corneal power compared to the MYH.
Flatter K readings on the myopia master.
And it also consistently measured a smaller white-to-white distance compared to the MYAH.
So if you're tracking corneal astigmatism changes or maybe fitting complex contact lenses based on Ks or WDW, switching devices midstream could really mess things up. You might see a change that isn't actually real.
Precisely. That systematic bias is exactly why the researchers strongly cautioned against interchanging K1, K2, and WTW values between these devices in clinical practice.
Yeah.
And definitely not for research. AL is fine, these others are not.
Why would that happen? Why agree perfectly on eye length but disagree systematically on corneal shape and width? What's different about how they measure the front of the eye?
It likely comes down to the specific technology they use for corneal topography. The MYAH uses Placido rings, those illuminated circles projected onto the cornea. It analyzes, I think, 24 rings. That gives a pretty wide map of the corneal surface.
Okay, Placido, classic technique. What about the myopia master?
It uses a different approach. It relies on analyzing reflections from a central test spot and also a central ring. It might be sampling a slightly different, maybe more central area of the cornea compared to the broader Placido analysis.
Ah, so they might be defining or measuring the corneal center or its curvature based on slightly different optical principles or areas.
That seems the most plausible explanation for the systematic difference. They're both measuring the cornea, but how they measure it leads to slightly different, consistent offsets in the K and WTW values.
Right, so let's tie this all together. What's the big takeaway message for practitioners listening?
I think there are two key takeaways. First, incredible consistency. Both the MYAH and the myopia master provide highly repeatable axial length measurements. That's fantastic.
And crucially,
And crucially, that consistency holds up regardless of whether the operator is a 10-year veteran or a final-year student, provided they get basic training on the machine. Operator experience seems less critical than the tech itself for AL.
huge validation there. But we need that caveat, the limitation they mentioned.
Absolutely. We need to remember this study used cooperative young adults. Your average patient needing myopia control is, well, a kid.
Right. Less cooperative, shorter attention span sometimes.
Exactly. So while the technical repeatability of the devices is proven, achieving that same, how might that small systematic difference in measuring corneal shape affect things that rely heavily on precise K readings? Like, say, designing custom orthokeratology lenses where tiny changes in corneal shape are the whole point of the treatment. Does that technological difference potentially matter more in those specific, highly sensitive applications?
That's a really interesting point. How the fundamental measurement method might cascade into treatment planning. Definitely something to keep an eye on.
Food for thought as we rely more on this tech.
Excellent deep dive. Thanks so much for breaking that down.
My pleasure. Always interesting stuff.
Indeed. Until next time on The Deep Dive.